Hi all, this is Sheena Bull. I'm gonna get us kicked off this afternoon. Welcome to this session for the Population and Mental Health Conference. I wanna share with you, this is the conference track C, and we're talking about mental health and technology in this session. And we have a number of speakers, and we're very excited to have our rundown today. I wonder, Jennifer, if you would put up the list. I think we may need to start with Dr. Mishkind, if that is okay. Would that be okay, Matt?
Yep, that works for me.
Okay. So, and we'll come back to Dr. Bordnick after that, if he's able to join us. And then I'll be talking and Dr. Rizzo will close out the session. But we're gonna have, each speaker is gonna speak around 10 to 12 minutes. We'll have some time following each speaker to ask questions, just a few minutes. And then we'll have some open time at the very end for Q&A. So certainly if you have questions in between the speakers that are specific to the person who just spoke, that's fine. But then also just consider that if you don't get your question in, you'll have time at the very end to address the panel as well. And you can circle back to any one of the panelists as well. So I'm going to turn it over to Dr. Mishkind and have him kick us off.
All right, thank you. Let me pull up my screen here. I probably need to switch my settings. Does everybody just see my slides now, not my notes? All right, Skip said yes, so I'll count them. So, yeah, thanks everybody for popping in today and showing up. My name is Matt Mishkin. I'm the Deputy Director of the Johnson Depression Center, and then also Director of Operations for the Stephen A. Cohen Military Family Clinic. And what I'm gonna kick off and start talking about today is the use of telemental health technologies, primarily to serve public health needs. So we'll talk a little bit about clinical services, and then we'll get into some training and education services as well. So the background, you know, I'm sure folks are fairly well aware of all these points, but continued access to mental health care is of paramount importance, really always, but certainly during the public health emergency, and for us, the COVID emergency that we're in right now. There are a few reviews out there. There was one that was published late last year, early this year, looking at previous quarantine and self-isolation measures, and found that that people actually reported a lot of negative psychological effects. And I think we're starting to see that now. We talk a little bit more when we talk about the data, but you know, when we first made this transition to 100% virtual services with COVID, we kind of knew that there might be a wave of need for mental health to come. We didn't see it initially. We are certainly starting to see it now. I think within the last several months, we have seen a dramatic increase in people reaching out for services. So a lot of healthcare sectors actually saw a drop in patient visits, and that was due to not being able to do the care because it couldn't have in-person services, people being nervous about coming into clinics, et cetera. As I said, mental health, we saw a drop, kind of a brief drop for a couple weeks. And then once people sort of got their feet under them with dealing with COVID, we have now seen a significant and consistent increase in mental health services. And then technology, and a lot of folks will talk about this today, can be part of a stepped care process to increase access. So we'll talk a little bit about our clinics. We made a transition to 100% virtual services on March 16, 2020. That's actually when we really started doing it. It took us about 2 days to make the transition. We did always have to caveat this in there. We had provided in our two clinics between 10 and 30% of sessions were telehealth before March 16th. So we had a bit of a head start from others, but we were able to make the transition within about 48 hours. That doesn't mean that everything was transitioned over perfectly. just means that we were able to really start services and operationalize the services within 48 hours. And we also saw, so we have an entire part of our clinics is devoted to community education and training. And we saw an increased demand for education and training services. And I've got some data to show on that. So what are we talking about? So with telehealth, there's a lot of different definitions. Probably the most basic one is it's a range of synchronous and asynchronous communication technologies that can provide care at a temporal and geographic distance. The geographic distance often makes sense to people from one location to another. Temporal distance can be a little bit confusing when we talk about it, but think about this in terms of an e-consult. So you send off something, so maybe you need specialized mental health services, you send off information to a psychiatrist. They might respond to you, 6 to 8 hours later. That's more of asynchronous, and that's more that temporal distance. We're really talking about medical education, clinical services, really anything that's having to do with providing healthcare services to an individual. There's some other terms for it: e-health, virtual health. You hear a lot of others, and then telemental health is specifically a subset of telehealth dedicated to the provision of mental health services. Typically, we talk about therapy and medication management, and today we'll talk a little bit about training and education. So what are the benefits of telemental health to public health? It can actually significantly impact increased access to mental health services. And that includes tailoring services to individual or community needs. It doesn't mean you have to throw a one-size-fits-all approach to everybody. You can actually see what a community needs and do a better job of tailoring services to a specific community. We do know that not everybody has equal access to care, and that continues to be an issue when you look at bandwidth and you look at even access to hardware. So it doesn't mean that it unfortunately has not gotten to the point where it just equalizes access, because there are still some concerns. But we are able to get especially specialized care out to people who don't typically have that care or may not have any of it at all. So it is used to significantly impact access. One of the things with it, when you think about all the technologies that we have the ability to put in place, from mobile apps, from web-based services, computer-assisted services, Skip and others will talk about virtual reality, is it allows us to actually do a better job of triaging what people might be able to do from a self-care perspective versus their need for professional services. So if you effectively can get sort of mobile apps out to people who have mobile apps with more self-care strategies, or doing things on the web that allow people, almost like WebMD, to figure out what might be affecting them at the time and can they get other resources for it, that helps triage what somebody might be able to handle on their own versus their need for professional services. So that's that stepped care approach, is this better use of all these different technologies to make sure that people have the appropriate services at the appropriate time. And hopefully you can use technology to not flood mental health clinics, because that's something we still see a lot of, is a lot of people when they're in a crisis situation, their immediate is to go to an outpatient mental health clinic that honestly isn't that well prepared to be able to handle the person's crisis at the time. And so the more services we can get that are closer to individuals, the more likely we are to prevent that need to get crisis services at that time, or to be able to direct it more appropriately too. So just a couple quick things. So in Colorado, we are very fortunate that we have a law that passed in 2017, which actually forced insurers to pay the same for telehealth as they do for in-person care. It also allowed for flexibility from where you could get and receive services. So a lot of places, even if there is parity, there might be limitations on where you can get and receive the services. Colorado is very flexible on that. So that was helpful in our move to telehealth services. And there's also more and more research being done showing that in-home, which would be telehealth services delivered to a patient's home, is feasible and a good alternative to in-person therapy or more traditional clinic-based services. Interestingly, what we're starting to see now and what happened with COVID is when we talk about in-home telemental health, we're actually talking about provider home to patient home. So it's actually given it a much more in-home flavor to it. Typically, it used to be a provider might be in a clinic and they would deliver services to a patient's home. Nobody's in the clinic these days, so everything is being done home to home. And what we're showing is this is a very effective way for us to maintain access to care. I have this one up there. This is always kind of that fun one to look at, sort of digital native versus immigrants. Always something we need to think about with technology. You know, we can't assume that people that we're seeing have this great understanding of technology. So for us, one of the things that we had to do before we signed somebody up for telehealth services, we do test calls with folks to make sure that, one, they have access to the proper bandwidth, they have access to the technology, and they understand how to use the technology. So we can't make assumptions based on any sort of age or demographic that somebody does or does not have an understanding of technology. So what we do is make the assumption that people need to have at least one lesson, at least one ability to, or one time to check things out. We do that with everybody. And allows us to kind of get away from this mentality. So what do we see? As I mentioned, we've seen an increase just in general need for services across the board. But we've seen, and I actually think it's now, from the time I did these slides a couple weeks ago to now, I think that we're closer to a 20% increase in the number of sessions scheduled. So one, that shows that there is a need out there. If you look at our no-show rates, it has decreased from about a little over 10% to about 7%. So not only are we just seeing a need across society, but we're actually better able to meet that need now via telehealth. And that's been one really amazing thing with the technology. I'm not here to say that telehealth is a cure for everything. There's certainly folks who benefit from it. There's certainly folks who may not be great cases for telehealth. We are actually talking, I think we'll talk more about this later, about hybrid services. So figuring out how to actually deliver telehealth and in-person services to the same patient. What time, when is it best to give telehealth services? When's it best to give inpatient services? But across the board right now, since everything, at least for our clinics and across the board for most clinics, are still 100% virtual, telehealth is meeting the need that people have to the best we can. As long as there's providers to provide the services, we're meeting the need. Another thing, and I throw this up there as we talk about policy, in one of our clinics, we see Medicare patients, and Medicare had some pretty restrictive policies. We were seeing about 3 patients a month pre-COVID with telehealth that were under Medicare. We're now seeing 88 patients a month post-COVID with Medicare. So you saw this significant increase. And if it weren't for the flexibility of policies, that wouldn't have changed. We would not be seeing those 88 additional people. And unfortunately, I don't mean that we wouldn't have had the increase. We literally would not be able to see those people since everything went virtual. So here are some of our numbers. I talked about decreased no-show rates. It's just giving sort of a perspective of the number of sessions that we've been able to schedule. And it's, we're just around maybe a little over 1,100 sessions a month right now that we're scheduling, again, all through telehealth. One of the other interesting changes we've seen is for a long time, anxiety was sort of our number one concern. Sometime around April, we started to see a little bit of a shift. And you can see I've got them in bold up there. The shift there went from, not that anxiety is off the chart anymore. We're not seeing folks who are coming to us with anxiety, but we've seen a distinct increase in the number of people who are coming to us with depression. And if you wanted to add bipolar in there, you would see, both of those have gone up. Bipolar, not so much, but certainly major depression has gone up as we continue on in COVID. So that's just more, discussion point. It doesn't have that much to do with telehealth other than the fact that telehealth is able to see all these types. And so just because we've seen a change in diagnosis doesn't mean that telehealth is no longer effective. I mentioned training. So this is just some data on our training programs. So before COVID, we were doing about 10 trainings a month. Now we're doing about 16 post-COVID. And interestingly, when you think about a public health approach and focusing on training and education, our average participants per session has gone up 2978. So not only were we able to do more trainings, more people are showing up for those trainings. And we've also noticed we do trainings in workplaces, that workplaces are reaching out more, I think largely because they're starting to tune into the fact that their employees have concerns, but also when you think about just the logistics of trying to get into a business, even go into the business, having people take their time off, that's not happening as much. So we're seeing much more demand from businesses, and our trainings in businesses have gone up as have the average participant. These are just some opportunities here. There is widespread adoption. I mentioned again, looking at the idea about this hybrid care of in-person and telehealth. We do still have some challenges. I talked about regulations. We don't know how many of these regulations are going to last. And if they don't last, we don't know when they're going to get back. That's always a concern. Certainly everybody's talking about Zoom fatigue these days, which is just in my mind, fatigue in general. We're not able to always keep up with the technology changes that are happening. So there are some challenges. There's certainly some great opportunities here, but we aren't without challenges. This is a slide on hybrid care. So to end, what we've seen is that telehealth is a viable option for not just continued provision of services, but actually helping to meet some of the increased demand. Again, it doesn't do anything to produce new providers, so we always have that concern of there's got to be a provider on the other end. And one of the challenges we're seeing is that our providers are starting to hit some burnout because more and more people are seeking services. And while it's great to have reduced no-show rates, that's putting more of a burden on our already burdened and limited provider base. So we know that across the board, there's going to be transitions. We do expect much wider use of telemental health, and I expect it'll turn into this hybrid approach as we move forward. And again, it's not just clinical services, but telehealth has been shown to be very effective in our ability to provide training and education services and reach a broader audience with those services. So that's it for me. We'll have some Q&A. I think we're doing only Q&A at the end, or are we going to take some now?
I think we have time for probably one quick question if folks want to pose it to Dr. Mishkind. I think you can either just jump in or put it in the chat. Okay, well, we'll move back, and if you have additional questions, you'll be able to pose them at the end of the session when we're going to have the whole panel responding. So thank you very much, Dr. Mishkind. As is typical with every single conference presentation, whether it's virtual or in reality, if it has anything to do with technology and digital health, there will be problems and challenges with technology. And such were the problems for Dr. Bordnick, who was scheduled to set us off this afternoon. But he is with us now, despite some earlier connection issues, so we're welcoming him. And he's going to take a look at mental health and technology broadly. So welcome, Dr. Bordnick.
Thank you very much. Yes, I love we're talking about technology and we have connectivity issues. So it's always my favorite way to go, but hopefully you can see my slides. I'm going to sort of present a variety of research that involves technology, primarily virtual reality, which we've been doing across the country for well over 16, 17 years. I'm currently the Dean of the Tulane School of Social Work, and we are working with the National Center for Mental Health Innovation in Colorado to really bring this work to the home user on portable technologies. And I collaborate with one of the other panelists as well, Skip Rizzo. So I'm going to be sharing sort of where we're at and what we do with the work and how we think about it theoretically, but also how to implement it. See if my next slide will advance. There we go. Most of you know this data. It has not changed in many, many years, unfortunately, and usually with underreporting on these national surveys. But when we look at substance use in the United States, About 1 in 12 adults have had a substance use disorder in the past year, and you kind of can scale that up with binge drinking, or adults have used drugs in the past year, 1 in 10. And where we really look at substance misuse and dependence doesn't occur in a vacuum. Usually you have comorbid disorders such as mental health, and when we couple that with 1 in 5 US adults have had a diagnosis in the past year, you can then see the interplay as we go forward. So we're not just treating mental health by itself usually, or addiction. Usually we're dealing with co-occurring disorders. So I always like to start off when I present giving the full picture, as well as this slide where we address stigma. Unfortunately, no matter where you go, even with all the information out there, obviously we're in friendly circles today, so I'm preaching to the choir. But in the general public, substance dependence and misuse, or mental health or behavioral health, is still highly stigmatized. There's a great quote from Bill Clinton up there about mental illness is nothing to be ashamed of, but stigma and bias shame us all. So we always want to talk about it. The picture on the left is my daughter, and I have her permission. I talk about her all the time to help reduce stigma. She has autism spectrum disorder and severe ADHD. And we use some of our technologies, virtual technology, to empower young people with autism spectrum disorders. So again, if you just look at my family alone, we are well within the 1 in 5 huge history of substance abuse in my family. My father's been in recovery for 35 years. So this isn't, as most people think, someone else. It's every single one of us. That's the one thing about mental health and substance misuse and dependence. It does not discriminate. It doesn't matter where you're at, how much money you have, or anything else. It affects all our families. Which brings me to this slide, which this is what I've been doing for the past 18 years in the research space. And this literally involves every drug that we have studied, either with virtual reality or in our standard behavioral lab, starting with the first drug that we ever studied, which was cocaine. And it was the substance that really got me interested in this idea of relapse and craving. It's where my work really started and sort of led into virtual reality. And then obviously looking at alcohol, cigarettes, cannabis, cupcakes. I just threw that in there because who doesn't like a cupcake? Not really. It's some of the same centers, the pleasure centers of our brain that are involved in eating, are also involved in substance misuse and dependence. And again, related to impulsivity and behaviors, when we look at work of STIs, huge rates of STIs we've seen in substance misuse and dependence because it decreases our inhibitions, and we can get into issues. And then also looking at compliance and how people are compliant with treatment, or even doing behavioral compliance with something like condom issue, or if we want to bring it full circle with the mask usage currently, there's a lot of parallels. People non-compliant with masks are wearing them correctly. It relates to that public health and shaping and changing people's behavior for common good and change. So in substance abuse, we really think about traditional therapy, especially evidence-based interventions. We usually use role plays. So if someone were to come see me many years ago and wanted to learn skills to manage their craving or skills to not relapse, we would sit there and pretend the person was in a bar or in a heroin shooting gallery, in a place where they had used cocaine or other drugs before. And we would do role plays. Okay, so pretend you're walking up to the bar, I'm the bartender, and you go through helping them practice assertiveness training, some skills not to order a drink or to leave the bar, and to manage their craving. Well, it always bothered me. I kept thinking, is the patient buying this? I mean, we're saying the right lingo, we're having them imagine they're in the situation, but it always bothered me that we were doing this in a clinical office or a laboratory setting. It wasn't in a bar. It wasn't in a place where they have used cocaine. So how could I expect them, when they're in those situations after they leave the clinic setting, to be able to practice these skills that we're teaching them essentially in a situation that's incompatible with where they would learn to practice or utilize these situations. So really in the clinical setting, we lack the context of the situation. We lack links to the real world. And what we've saw over the years is we've tried to approximate a lot of these things in the lab. So there's researchers out there that have built bars or built different settings in their labs, but it's just not feasible and not scalable to be able to do this from any type of treatment setting. So we started thinking, how do we leverage technology to be able to bring these high-risk relapse situations into the laboratory or clinical space? And we stumbled upon virtual reality. And many, many years ago, when we started off, when you think about video games and virtual reality, we really started off early on in virtual reality with sort of cartoonish images and characters and shapes and objects. Whereas where we're at today, we got highly detailed models, avatars that look like you or I that can interact with you. So we've really been able to utilize the software and gaming technologies to develop high-risk relapse scenarios to be able to utilize them in treatment as well as research settings to assess relapse and craving. This is someone picking up a virtual bottle of beer in the lab, looking at sort of tactile cues, audio, visual, olfactory cues to really recreate that situation that someone would encounter in the real world in the laboratory, to not only understand relapse and craving, but then also to figure out how we can leverage these situations to empower people to not use in the real world. So what virtual reality allows us to do is bring these high-risk scenarios. You'll see several of them on the screen. Right now, you'll see a bar, a liquor store, a party, a gas station. Most people are often puzzled by the gas station. Well, one of the drugs that I initially studied was nicotine. Well, people relapsed to smoking. They would drive by a gas station. Well, behind every counter in a convenience store are walls of cigarettes. Well, one coping strategy before virtual reality was, well, just pay at the pump, right? So you just fill up at the pump. Well, then all of a sudden the cigarette ads started to be placed right there on top of the pumps. To this day, you can see them on the window washing little gizmo there. So again, these triggers to use that were in the store, they're all plastered on the outside of the building or right next to the pump. So really empowering someone that's trying to quit smoking to be surrounded by these cues. Also a convenience store in many localities across the country, you can buy alcoholic beverages. So it can be leveraged as well as to teach someone, you have to get gas in your automobile, to also deal with the craving and potential relapse scenarios of going to a convenience store. And you just kind of scale these contexts up. So this, going back to our first drawing we went to, you can see that we've taken that setting where we would teach a patient coping skills to not use, and we put them in virtual reality with the clinician handling the whole situation, and they're in control of all the interactions and how high the peer pressure is in the situation if someone's offering a drink or a joint or what have you. And so the clinician's in charge, as well as they're observing what the patient is doing. So now we can bring these high-risk relapse contexts into the clinical setting and have the therapist teach the person skills. So now this mimics the real world. So when you're in a bar, you've learned coping skills not to drink in a bar, in the virtual bar, that then can be emulated in the real world. And we've published data on this as well, going out there. And we sort of have scaled this up. This is a picture of one of our heroin environments. This person is actually, this is one of our detailed avatars who's actually cooking heroin.
Using 8 infrared cameras, this system can track a study participant's movement while they use special glasses to see the world in 3D.
It adds another degree of realism to what we do. When they walk around, it's as if they're really walking around in the real world.
Participants are placed in situations that may tempt them to use drugs or alcohol. And by creating the real-world scenarios, Professor Bordnick hopes he can teach the coping skills necessary to help stop a relapse.
Our hope is in the future is when they go out into the real world that they'll remember this experience and they'll not use drugs and remember the skills we taught them.
So it's kind of going after what we were talking about. And as we get into I want to say, we're not in a post-COVID world. Again, thinking about how do we bridge the gap between being able to show up in a treatment center, but also preparing the person for the real world. So one of the things is to think about, most people are triggered by cues in their environment. So one thing we talked about is utilizing cell phones to mark or geofence high-risk relapse scenarios in the person's environment. This is actually my neighborhood, so I'm not marking anything in particular, but you would work with the therapist and they would geofence areas where you had relapsed before. So when you're there with your cell phone, when you hit this boundary, going through, you would see a warning sign. What's going on? Then you'd be popped up on your cell phone. You're near a place where you've relapsed before. Remember to practice a coping skill. Teach this, go in this sort of area and what you're doing, and then go on from there. So that's kind of the work we're doing right now. And if you want to learn more about this work, I'm trying to advance my slide. You can email me or get a hold of me on social media, or send a question. But the general idea is leveraging virtual reality technology, whether we're in a pandemic or not. This is a great way to bridge the gap between the clinical world and the reality where our patients live and have the highest rates of relapse. Thank you.
Great. Thanks so much, Dr. Bordnick. Does anyone have questions before we move on? We have time for one or two, maybe. I have a quick question. So you mentioned olfactory cues. Is it possible within these systems to have sense as well as visuals?
Absolutely. One of the biggest things are sense of olfaction. They trigger memories. I know Dr. Rizzo's done a lot of work with PTSD and warfighters, but also in substance abuse. A scent or a thing really triggers a memory of where you use. And a lot of drugs or alcohol obviously are associated with scent. So scents themselves are a primary trigger that tend to be very powerful. It's just a constellation of these cues or triggers that we deal with. But yes, we do have a scent machine that we've utilized. However, if you build the environments that are realistic enough, people tend to fill in the scents, actually. So if you see lemons and limes on a cutting board and you debrief with participants afterwards, a lot of them will comment how good the lemons and limes smelled, even though they didn't have it. It's kind of like the old Western movies where you just build the fronts of them. They're not real buildings or towns. The same thing, if we touch enough of the sense with realistic environments, people will start to fill in, and that's when we can leverage these technologies to be helpful.
Great. Are there other questions? Okay. Thank you, Dr. Bordnick. We're going to move on now and talk a little bit about technology to promote mental health and well-being among American Indian and Alaska Native teens and young adults. So this is work that I've done collaboratively, and I'm a professor in the School of Public Health in the Department of Community and Behavioral Health. We're moving a little bit away from the virtual reality and into the social media environment when we're talking in this presentation. So I want to consider the landscape of mobile and digital health efforts related to mental health for youth, and think a little bit about really what motivated the team that worked on this particular project using social media. And really what I want to emphasize here are a couple of things. So when we're thinking about population level mental health initiatives, we're wanting to think a lot about scale. And both of the previous presentations, thinking about virtual reality as well as telemedicine, are really starting to touch on this issue. How convenient is it for people to come into lab settings, and particularly now with COVID, it's not even allowable in many cases. And so what are ways that we can really reach people with mental health initiatives? And are we able to capitalize on opportunities for reach and dissemination? And I'll be addressing that, coming back to that throughout this presentation. And then I want to share some findings from the BRAVE project, which is a collaboration between the mHealth Impact Lab at the University of Colorado and the School of Public Health and the Portland Area Indian Health Board, as well as some other collaborators. And talk a little bit about that project and how we were able to recruit and enroll and reach folks. So just a little bit of context for mental health challenges in children and young people. So really the prevalence relative to other population groups may be considered lower, but at the same time, they are still not without concern. So when we think about using digital and mobile solutions to address mental health and promote mental wellness among children and young people, we have some growing evidence about what works to address some of those conditions. And one of the key considerations, though, is thinking about how do we best engage young people. So we can use digital solutions like cell phones or mobile apps, or even virtual reality like we just heard about, as well as telemedicine. One of the big challenges is, can we get people to use the tools once we know that they can be effective? And so engagement with content and with interventions is a key consideration as well. So in this slide in the middle, in that purple box, is really that issue highlighted. So in order for children and young people to be able to derive the benefit from anything related to mental health and wellness delivered digitally, they have to access that content. And I had to laugh with Dr. Mishkin's slide that showed I think the toddler telling their grandparent to, just download something, right? It's not necessarily an issue for children and young people to do that. But if you want them to download an app and utilize an app, they have to give up some real estate on their phone. For very young people, they may not even have that tool, for example. So on the top, you see that the types of things that influence engagement include the suitability, can they access content, and convenience. So asking people to download an app and utilize and engage with an app may be challenging if you've got competing things that they're doing with their smartphones. Then there's always features around usability. Is it easy to use, easy to understand? With the population that Dr. Mishkin was talking about related perhaps to older people, that may become more important, where younger people may be digital natives and may have less concerns about usability. It still doesn't negate the importance of making sure that whatever it is you're doing can resonate for the populations that you intend. And then acceptability, does it have the features that you would expect? So with young people in particular, there's another thing I noticed, maybe some of the cultural references from Dr. Bordnick, that I'm going to date myself, but I recognized Pac-Man, in the earlier kind of more rudimentary gaming. If that's what we're showing on our tools, when young people in particular expect to see well-formed, sophisticated avatars, you're going to have difficulty in getting them to resonate with what you're trying to deliver for them. And then on the bottom set of blue boxes are really more those individual influencing factors that really get people to think about, is this intervention or is this tool digitally something that I want to use? And I'm going to highlight in particular that middle box, the issue of trust and anonymity, and thinking about what people are able to engage in the digital environment really is influenced quite a bit by those factors. So when I talk about the project that I'm presenting on now, it's a partnership between multiple folks. So I mentioned the Northwest Portland Area Indian Health Board, and that's a picture of their staff right there. They are the folks that really have came to us, the mHealth Impact Laboratory, and a couple of our students and recent grads that have been working with us on evaluating the effort, as well as Dr. Julia Robel from the Center for Innovative Design and Analysis here at the university. So the Northwest Portland Area Indian Health Board has a mandate to assist Northwest tribes and improve the health status and quality of life for member tribes and Indian people in the delivery of culturally appropriate and holistic healthcare. They have developed and gotten quite a lot of interest and credibility through the use of a website that they have been supporting for many years called We Are Native. And the website has become a very popular place for Native communities to come and get information that's targeted towards them with content that is relevant for their daily lives and for their tribal communities. And so We Are Native is a platform that already has that level of trust and a real large community that utilizes the services that they have. And until recently, until this new initiative that I'll share with you, most of this was fairly static. It was information-based. It was and shared content around a number of different topics. It's not exclusively static, though. There is a feature called Ask Auntie, where people can post questions to a community leader who would answer specific questions for specific topics. And sometimes they can do campaigns that would focus on particular topics. In an effort to really build out content related to mental health, the We Are Native team determined that what they wanted to do was, first of all, get a sense of what are the mental health topics that are most important to young people using the We Are Native site. And so here you see a breakdown where the largest elements are around grief or depression. Another big area where people wanted some information was just really on how to maintain mental wellness. Other topics were trauma, intergenerational trauma and PTSD, as well as suicide and anxiety, for example. So these were questions posted on the website in advance of developing content that was specific to young people focused on mental health. And we realized, so we wanted to go back to those issues related to how to best reach people and engage people. And from a lot of work that we've done over the years with the mHealth Impact Lab, we realized that even though you could have a utilization of some very sophisticated apps, or now we're seeing the advent of sensors, for example, things that you can use like a Fitbit or other tools that can track and give you feedback. We really feel like there's a benefit in reaching people where they are, and particularly young people. That means going to social media and some opportunities for text messaging, for example. And indeed, when the We Are Native team asked young people, the most popular kind of communication tool from We Are Native was through text messaging, and then followed with Instagram as a social media platform. And so based on that, the We Are Native folks decided to develop the BRAVE study and rigorously evaluate text messages and role model videos that would be placed on the We Are Native site to see if it could impact youth norms, intentions, self-efficacy, and behaviors related to mental health, cultural resilience, and help seeking. So we did a 2-arm cluster randomized crossover design study with the group. So our Denver team, University of Colorado team was responsible for the evaluation of the study. And we did national level enrollment of folks that were connected to the We Are Native website, as well as paid advertising on Instagram and other social media sites. And then we assessed them at 3 months, 6 months, and 9 months. And at 3 months, at the time of enrollment, they were randomly assigned either to get content that was related to mental wellness, or they were assigned content that was related to STEM, just for educational purposes, you know, the encouragement to engage in STEM kind of training academically. Participants had a crossover after the first engagement, and then discontinued intervention and control content at 6 months, and then did a final follow-up at 9 months. So just some screenshots of the content. These are some of the Instagram posts that were up. Just some information on some of the videos that people could access through their text messaging, and also some of the text messages that were posted to folks. We were able to enroll 2,300 participants, or recruit, sorry, 2,300, and enroll 833, of which 648 completed a 3-month, 562 a 6-month, and 513 a 9-month. When we combined the data, we saw that there were 464 respondents who completed 3, 6, and 9-month data that we were able to analyze. People were from all over the country, but we did see the biggest numbers in the Northwest, where the We Are Native team resides. We had most of our participants clustered around the 15 to 18-year-old group, and then it dropped off after that up to about age 24. And when we looked at our outcomes, we wanted to recognize that we actually saw a positive change in everything with the exception of cultural pride and identity, which didn't really shift over time. And this was seen even after the intervention ended, so in a potential decay period. So we're happy about that. One key thing, though, is that we didn't see a difference between intervention and control. So we had good retention, and we did have significant impact on those outcomes from folks, which makes us encouraged that you can use these platforms to impact people's antecedents to some negative mental health outcomes. But it may not necessarily have as much to do with the content as it does with the level of trust or connectedness that these participants had with the We Are Native team. So that's something for us to explore a little bit more. And I know I'm probably at time, so I'll end there. So I think, unless there are questions, we could move to our final speaker and then open it up to questions from everybody, but I'll just check and see if there's questions right now. Okay, with that, I'm going to turn it over to Dr. Rizzo, who's going to talk with us about clinical virtual reality among veterans. So thank you for being here, and please take it away.
Okay, I hope everybody can hear me, and I'd like to thank the organizers for inviting me to present today. My talk is going to take a little bit longer view of our work, talking about PTSD from combat to COVID, and that will become apparent as we move forward, the direction of the talk. A lot of the work I'll be presenting today comes from the University of Southern California Institute for Creative Technologies when our lab which is the medical virtual reality lab. And over the years, we've done quite a bit of work in different areas. One, for example, that I'll talk about today, virtual reality for exposure therapy, for combat-related PTSD, and for resilience training. We'll see more of that, so I'll stop that now. This is what that system looked like about 12 years ago. In this case, we retooled it for testing cognitive function. So taking the exposure therapy world and translating it to test of attention, memory, and executive function. And I include this so you can see the advances in the graphics that have happened over the years. We don't just do military work. This is from 1996. Some early work with 3D manipulation of visual spatial items for testing and training cognitive functions. Some later work with a virtual classroom for testing children with attention deficit disorder. This has evolved into a product that will be available soon, but in this form, the child pays attention to what's going on the blackboard within a psychologically relevant environment. Meanwhile, distractions occur that are designed to test the child's distractibility from the content. What you're seeing is actually a video from what a child sees as they turn their head in the virtual classroom. We've also done a lot of work with motor rehabilitation. It's using a Microsoft Kinect camera to track full body action and to try to make very boring, repetitive, and frustrating activities of physical and occupational therapy more fun and engaging by putting it in a game context. And more modern versions of it include head-mounted displays with sensors that track hand movement and allow people to interact in these hopefully compelling worlds to get them to do more of the physical rehab that they can benefit from. Finally, our work with virtual humans. One project with the military was working with USC School of Social Work for building virtual patients for training clinical providers in a military social work program how to conduct proper clinical interviews like this.
Good afternoon, Sergeant Castilla. What brings you in today?
Well, my wife told me she thought I should talk to someone. She's been pretty concerned about me since a soldier suicided on base last week.
Did you happen to know the soldier?
Yes. He wasn't a friend, but I met the Marine once or twice. He seemed normal at the time. I guess I'm afraid I might end up like him.
Do you have any plans to hurt yourself?
No. It certainly crossed my mind, especially lately. I just need it all to stop. Sometimes I can't handle it.
So I like to say that applications like that give clinical trainees the opportunity to screw up a bunch with a virtual patient before they get their hands on a live one and learn from those trial and error experiences. Finally, one last app here. This is one we designed for the military as well for breaking down barriers to care. Virtual agent that could be accessed on a website that you could ask questions to, and he could ask you questions, and you could find out about PTSD, TBI, substance use. And I believe Patrick was involved in this project. It's an old project from, I think, 2010. And the character could also ask screening questions in a conversation and give you feedback on your state and recommend treatment and describe what treatment would involve. I'll just let him introduce himself really quick.
Well, I'm not a real person, if that's what you're asking, but I'm based on the personality and experiences of real soldiers and Marines. I'm still just a piece of software, but I'm getting better all the time, so hopefully I can be a helpful piece of software to talk to.
So I don't want to belabor the point about what virtual reality is. I'll just touch on it real quick because Patrick's already covered it a bit and everybody should have a sense of it. But it's an integration of enabling technologies, computers, interface technologies, body tracking, sensory displays, all to support putting a user in a simulated environment for a specific purpose. And, you know, you can look at it from a more human-centric, a human-computer interaction point of view, ways for people to interact with computers and complex data in more natural ways. You know, if we look at human-computer interaction over the years, maybe VR's time has come, not limited to hunting and pecking on a keyboard. The best metaphor in mental health and rehab is aviation simulation. So just as an aircraft simulator can serve to test and train piloting ability, we can test, train, teach, and treat psychological, cognitive, motor functioning And in some sense, the best metaphor is the ultimate Skinner box. Since the birth of clinical VR in 1994, where it was primarily focused on exposure therapy for specific phobias, in this case, fear of heights, we've seen these clinical populations as really a short list where research has documented the value of using VR either as an assessment or a treatment or a tool for scientific research with these populations. A lot of reasons why VR comes to play here. I'm not going to go through all of these, but if you're interested, there's an article that came out in, I believe, the end of 2017 that details all the reasons why we use VR and how it's impacting the future of healthcare. But you can distill all this from these 5 points. You can expose people to things like exposure therapy, as you'll see more of. You can distract people from painful medical procedures. For pain reduction, you can motivate people to do things they might not ordinarily do, as in the physical rehab case. You can measure performance, and you can engage people in these simulated worlds in ways that might be difficult in the real world. Now, in the exposure area, people have done tons of research, and I'd like to say that, the scientific literature for VR applied to mental health and rehab is probably the largest body of science of any VR use case, and a lot of it has been in these areas. One of our focuses, of course, has been in the area of post-traumatic stress disorder. And we got involved in this in 2003 and moved forward in 2004 with funding in response to the challenge for returning service members coming back from Iraq and Afghanistan. But now we're facing a new challenge. And that is the residual impact, or what I call the third wave of COVID, which is the residual mental health challenges. And I'll talk about this study in a bit. But this is what PTSD exposure therapy looks like.
By going through it there, it's not going through my head at night when I'm trying to sleep or when I'm with my wife, times when I don't want it to come up and me start thinking about it. Traumatic things are not normal. You cannot handle the things that you've seen and done. And this is a tool that has helped me out tremendously.
Reliving the worst moments of his life has helped him to move on with his life.
I'm probably about 80% of who I was before I left, but I think that's pretty good after seeing and doing the things that you've done.
For Nightline, this is Dan Harris in Atlanta.
So one thing to keep in mind is that virtual reality is not a magic bullet. In this case, we're really doing it in a way to amplify what's already known to be an evidence-based approach, prolonged exposure. And the way we do that is give the clinician an interface that allows them in real time to customize the real-time activities in the virtual world to mimic the story that they're narrating as part of the exposure process. And so the clinician sits in front of the control panel and within any of 14 worlds can make the time of day change or different gunfire or fog, sandstorm, helicopters flying over, IEDs going off in any direction and so forth. The research over the years has been relatively positive in the sense that our first open clinical trial showed really good results with the first 20 treatment completers showing progressive improvements. This is finer point put to it. 16 in the first study no longer met PTS criteria, 4 did not benefit. Over the years, people have done larger studies. This with Deborah Beidel's work at the University of Central Florida, showing very powerful impact when VR was combined with trauma management therapy in an intensive format, 3 weeks of intensive treatment. Every morning do VR, every afternoon do a combination of traditional talk therapies and customized treatments under the rubric of trauma management therapy. We've done randomized controlled trials. Matthew was involved in this one with our older version of what we call BraveMind, which was limited to 4 worlds. And in this scenario, in this study, we found equivalent results with evidence-based treatment and post-treatment, although the longer-term follow-up was not as effective. And I think part of that was we had a very limited collection of scenarios that we could put people in. That's changed. We went from 4 worlds when this study was done to 14 different worlds. So now we can really put people in context that are relevant to what they went through. And that was done in this study here, where again, we found equivalent findings with PE. This study's under review, but we also dug deep with pre-planned comparisons showing VR outperformed traditional prolonged exposure when people had comorbid depression. And that really is a large body of the people seeking treatment for PTSD. And that was predicted. We also expanded the work now as we move from combat to other areas with military sexual trauma, working with Barbara Rothbaum at Emory University. We thought we were having an easy go of it, just modifying our combat scenarios, but we found out from our clinical interviews that most patients suffering military sexual trauma were traumatized in the United States, around US bases and so forth. So we had to build out a lot of civilian content. Keep in mind, we're not replicating a sexual trauma, we're replicating the context of the trauma in order to help a patient to confront and reprocess these difficult emotional memories as what follows with prolonged exposure. And in order to do this work, we had to do a small sample size safety and feasibility trial to make sure we weren't hurting anyone. These are the results from it. Not only did we show no critical incidents where people were having more difficulty than before we got them, but we showed clinical improvement, even with a small sample, with relatively good effect sizes here. More work is needed in this area now with a full-scale trial and translation to civilian sexual trauma, which is one of our directions. But one of the key elements here is that, efficacy, I think we've documented with, probably 16 studies now that have been done by independent groups as well, that this is an evidence-based approach for delivering exposure therapy. It's residual and has long-term impact, 3 months down the road, but it shows a high level of stress in these individuals. So, certainly no shortage of trauma in the world, certainly a marketplace for it, and certainly VR will play a role in that marketplace. So our work currently now is with an online survey that mimics the surveys that were used in the Chinese study so that we can have a comparison sample of data to look at where they're coming from and to surveil the problem and to see where we stand with healthcare providers, with survivors of COVID, with family members of COVID victims, anybody, to get a sense of the problem. And then we were proposing a solution that doesn't simply rely on VR, but we call it a cross-platform wellness support system, where we leverage all the things we learned from the military and apply it for civilian needs. And this includes online, like SimCoach type healthcare guides and support agents, direct VR exposure applications for medical providers and people with COVID, relaxation scenarios. These are things that can be done in standalone VR headsets where you don't have to have a high-powered computer. You can buy a headset for $300 that delivers this type of content. And our early work leveraging from the military with online support agents that pop up once a day for 3 minutes or longer and engage you in different types of activities that help you focus on your mental health and wellness. So there's not a one-size-fits-all, there's no one magic bullet, but we believe that leveraging the kinds of things that the military has driven during the urgency of the PTSD crisis after due to Iraq and Afghanistan conflicts, now we have another source of stress that is going to demand our attention and our best efforts to improve the state of things. So anyway, the civilian mobile app that we're working on with a virtual agent. We know that VR is predicted to have a high place in the marketplace after video games and entertainment. Healthcare comes in second in the market share predicted by Goldman Sachs. Those numbers are going up each day as the technology evolves and as people see what the COVID situation has done with the greater adoption, as Matt talked about with telemedicine. I think what we've done in 6 months, what would have taken 3 to 5 years previously without COVID. So let's try to take this crisis, never let a good crisis go wasted, and try to evolve healthcare in a positive way, to evolve the work that can be done. This is just an example of the marketplace. The first image here was a company from '95 that still exists, but these are companies that have popped up in the last 2-3 years doing this work, more in the last 2 or 3 years than the previous 20. And certainly scientific conferences are evolving everywhere to address the advances in technology applied to medicine. I think ignore this at your own risk. This is where the future of medicine is going to go. Certainly not throwing out all the existing methodologies, but maybe amplifying or extending their access by use of technology, whether it's VR, mobile apps, or whatever. Quick shameless promotion for a book. And Patrick has a chapter in there, and I'll stop there. Thank you for your time and attention.
Great, thank you so much. And Dr. Mishkind is going to lead us in the final Q&A.
Yeah, thanks everyone. Hopefully you can hear me. I know, sorry, I've been having some microphone issues here. So check in the chat. If anybody has any questions, please put them in the chat. I have a few, so I'll start with those. I guess this would be for Patrick and Skip to start with. And Skip, you kind of noted this in some of the previous studies where you've gone from 4 to 14 scenarios. You know, and Patrick, jump in here too. How realistic to the actual scenario does VR need to be effective? And with that is, how close to reality and far away from gaming or close to gaming does a system need to look like? What have you seen in those two areas?
Patrick, you want to go?
Yeah, and then I know you have something to say. Skip and I have known each other for almost, 18 plus years on this. And it's that idea of fantasy versus reality. And what I've done in my lab and known Skip's work for many, many years as well, it's recreating the real world. We're leveraging gaming technologies. So, the quote I always use is, if you're trying to stop smoking pot, yeah, it would be great if Bart Simpson offered you a joint, right? A cartoon character. However, that's not your reality. That's not what you're going to experience. That person needs to look like me or look like you or look like someone on the street. So when you run into that person, that's going to evoke those biological and behavioral and cognitive triggers. So now you're prepared to deal with them when you're feeling your chest tighten, or you're feeling the craving, or you're feeling your mouth watering to hit a joint or to inject heroin or something. So it's not hard, but it's really working. And Skip's done a phenomenal job. And I know my work is in that vein as well, trying to work with CG artists and getting them to know it's not a game. We're leveraging game technologies, but a scotch and soda has to look like scotch and soda. It just can't look like a yellow liquid in a glass, because that is what that person is going to be triggered by. And I know Skip's work, I'm sure you can talk about your Skip's work. It's along the same.
Well, I think certainly, just from face validity, we have a cohort that's grown up with high fidelity graphics, and, we could get away with less fidelity back in the day. And in fact, we found that even if it was less fidelity, as long as you get certain features right, you could activate and engage people. That the beauty of all this is that we can fool the brain. You go in a fear of height scenario and they ask you to stand on the edge of a skyscraper and look down. You're on a solid floor. Your frontal lobes are telling you, yeah, you're safe. But your limbic system is reacting to the perceptual array of that height scenario. And all of a sudden your heart rate starts racing. Maybe you start sweating. And if you ask the person to step off and jump, they're going to really hesitate. They may do it eventually, but take some coaxing. So, the suspension of disbelief and the fooling of the brain can be done with low fidelity content. But I think we aim to make it more relevant. And with the PTSD, certainly we're not going to make an exact replica of where somebody was traumatized, but we can get the elements enough to activate the emotion to work with as what would be recommended within a trauma-focused exposure model to be able to work with that to foster extinction learning.
Thank you. Sheena, I've got a question for you. So talking about mobile apps, and you kind of touched on this, is, one of the things we know is that people download a lot of apps and then don't use them. And you touch base on this, but what would you say, and what from your experience is a way to engage people, and where have you seen, and I know you talked about some of the graphics and things like that, but maybe from more of a behavioral perspective too, how have you been effective at getting people to engage in mobile apps after they've actually downloaded them?
Yeah, it's actually a really great point, and I would caution that the experience isn't really that positive. So we know from research on digital and mental health apps, just generally, there's something on the order of 300,000 apps that are out there available for people to use related to health in some capacity, right? And of those 300,000, fewer than 0.1% have actually been evaluated for clinical validity. So we don't, first of all, we're not sure that they're actually working to do what they say they're going to do. But then a more disturbing concern is that the median number of times they're opened after being downloaded is 1. And so we're not getting people to open up apps. Now, what I think we're starting to see is as people pay more attention to engagement and these issues of engagement, how do you connect with the audience that you want to serve? So it seems clear, if you have a good deal of trust with the community that you want to work with, if you're a known entity, if you're a clinic provider and you want to promote a particular tool, it seems to work better. So people have a real world cheerleader or advocate for the tool. Seems to be required before people will actually take the steps that are needed to engage in it. So if somehow it's connected, if it's been developed by or endorsed by a clinic or a provider, that seems to be the only thing that we're seeing that will increase that number.
Thank you. We have one from the audience. We have one on. We got a couple more minutes, so I think Vivian, why don't you throw it out, and then we have one from the chat if we have time.
Hi, I'm Vivian Zhou. I'm working with Sheena Bowl in the mHealth Impact Lab in the Colorado School of Public Health. So I actually have 2 questions for Brodnick and also Riesel on the using of virtual reality. So you mentioned, Dr. Brodnick, that the current study you are doing is to use the geofencing technique and identify the risk areas, and whenever they enter that area, pop up warning messages. So, and I know you also do a lot of work in virtual reality. So do you see any potentials of like combining VR technique or AR technique to integrate that into the geofencing, that mechanism? So that's the first question. And the second one is, I think, to both Dr. Riesel and Dr. Brodnick, is regarding the scale of VR interventions, because we know there are a lot of barriers of using high quality VR equipment. It may cost several $100s to use at home. So how do you foresee the scale of VR interventions, especially in disseminating the interventions or VR apps to those who may have lower socioeconomic status?
I'll let you do the cost one, Skip, because you and I, we share the same view on that. Of course we do. I think the first part about taking the geofencing in VR, it's a good idea. However, we're not always wearing a headset. When we get to the point where we've got contact lenses that can project things into the environment, or people always, I'll catch a little bit of heat for this. I like the Google Glass, right? Because it was something that you could actively do. It just wasn't what we would expect. Where the geofencing comes in, it really reinforces the skill utilization that you develop. You do the VR, so you reinforce the skills, so they become automatic. So when you're in a situation, the context triggers not the drug craving, but triggers the skill usage to not use. And where the geofencing comes in, it's a reinforcement. You know, we know in between sessions with patients, our biggest concern for relapse is in between sessions. It's not during our session. It's not while you're in an inpatient unit. It's between sessions going home. So if we can bridge and find a way to be with that patient, to provide them some reminders or skills, it's just another way to help reinforce the work that we're doing. We were thinking about, you could pop up one of their skill usage scenarios, maybe a playback of their first person VR on the cell phone that may teach a skill. We're just not sure that you really need that. If you've learned the skill pretty well, maybe a reminder message, looking at their craving to kind of assess where they're at.
On the costs and the barriers to adoption, very important question. I think that the new wave of standalone headsets, excuse me, these are like the Oculus Quest, Pico Neo, these companies that have produced probably the most commercially successful headsets, are in the range of $300 to $400, and all the graphic horsepower is being done on the headset, all the processing on the headset. And this is the direction this is going to move in the future, with one important caveat, that the next step with these standalone headsets is going to be a 5G connection to a massive cloud-based library of content. So then a clinician seeing a patient in one session can hit on their tablet or their laptop, download that content or stream that content, useful for that client, good to go. Next client, got a different problem, need a different setting, go to the library. Oh, I need this, bring that down. So access, delivery, and cost cannot be eliminated from the equation, but there are many positive things that are happening, driven by the gaming industry and driven by the VR industry that wants, you know, they want to see a world where, you know, every home has a VR headset, you know, like a toaster. You might not use it every day, but every home's got one. And then you're talking about a wider dissemination of engaging, compelling healthcare content that can be delivered in immersive environments where relevant.
Thank you very much.
Yeah, I think we're a little over time, but we'll go another minute or two, but, you know, kind of going off what Skip said is, I think we also have to think about how mental health care is reimbursed in general. So typically you get reimbursed for your CPT and that's about it. You know, the technology often doesn't get reimbursed, the location doesn't get reimbursed. So I think a lot of this is also looking in general about the overall cost of care and how we can get some reimbursements for general cost of care and mental health, not just sort of the one-on-one time that's being spent. What we find is that covers maybe 55% of the actual cost of care for mental health. So we really need to think about how we can do it more broadly. And as more technologies come, you know, I don't want necessarily companies to sort of take over from a profit perspective, but clinicians also have to be incentivized to utilize those technologies. And if they're having to put out costs for something that they're not getting reimbursed for, that disincentivizes clinicians from doing it. And I think, you know, there was a question in there about sort of, if I would put it sort of like the private, you know, expert connection there, is you have to give the subject matter experts incentives to work with those private companies as well, and vice versa. And so that's looking in general about how we reimburse mental health services. So, you know, and again, I think as we talked about, there was another question about how we get these out, you know, to broader communities. I think broadband issues, information, you know, more resources just in general, I think are helpful. But I don't know if anybody else has ideas about that. You know, I think we all know that, like you said, the efficacy is there. Now it's how we take that efficacy and get it out to the communities and make it something that we can actually implement and integrate into our services. So if any panelists have any final comments, you know, nobody wants to end on my final comment, so somebody else make a better one. All right, I guess my comments are the final one. So thank you, everybody, appreciate it. You know, I think these are really interesting. I think you all got to see what we're doing now and certainly the future of what we're able to do with mental health care and how things are really, expanding and taking those next leaps. I mean, I think some of the stuff, Skip mentioned, I was on one of those original studies. What we talked about then and where we are now is just such a world of difference. And I think we're starting to really see what we thought we could do then, we're able to now completely do. So I really appreciate everybody. So thank you so much. If anybody else has any additional questions, put them in the chat, and I think then they can get answered at a later date.
Great. Jennifer, Jewel, is there anything else that we needed to do, or are we going to officially close the session?
Yeah, we are good to close it. I just wanted to send out one last reminder that the Flipgrid videos will be available after the conference as well. So if you haven't looked at all of those, then you can continue to do that. We'll probably keep them up for a few weeks, and definitely share the interesting ones with your colleagues as well, because there are a lot of good presentations in there. We have 25 total.
Great. Thanks so much, everyone, for participating. We appreciate it.